So this is going to be an interesting section of cyanotic heart disease. Who is the presenter? I think there is no need for introduction. Jimmer Srinivasan sir, he is our maybe godfather we can say, and you would have seen him. He is attending from the beginning till now for the past 3 days. Any conferences he will be like that. That's why I had the privilege of putting his session as the last session, because I know he will not go.
Okay, I have first question to all of you. How many of you have taken pediatrics by choice and not by compulsion by parents? Because father is having a clinic. Okay, so good. So majority of you are by choice. Good. So naturally you want to be a general pediatrician after MD. Then of course you may branch out. But as long as you are doing MD pediatrics, be a generalist. What do you mean by generalist? What do I mean by generalist? Anybody? Some name? I'll ask him. What is generalist? I'm sure you can become specialist in any subject. You are answering all subjects. Whether it's neurology or something, everything you are answering from behind. Come. Even answers, I don't know, he is answering from behind. So what is generalist? He has to tell the correct definition, and another definition he has to tell. Yeah. You get up, you take a mic around to go around. I'm not going to make it. He was my PG in Jipmer, so I am taking, now he is a professor. So I am giving him some this thing, yes. Yeah, generalist. That means you have to see the child as a whole, not as a part. And even the first slide and now what he mentioned, I am objecting. He said Srinivasan is going to discuss congenital, cyanotic, heart disease. Cyanotic, or I don't know whether he said cyanotic this thing, but he said heart disease. Is it a disease? Diabetes is a disease. It's going to live as long as the person is alive. But it's a defect. Okay, defect can be rectified. Now, all children can be leading a normal life, isn't it? So, no longer we should call congenital cyanotic heart disease, disorder. Just like yesterday she was mentioning, what are the 4 malformations? Disruption. So she mentioned, what are the various Ds? Defects, deformations, disruption, etc. Okay, so don't call it a disease. It's a defect which can be rectified. Nowadays, so many fetal heart surgeries are being taking place, and then there is a question always, either DNB or this thing, what are the conditions can be rectified, defects that can be rectified in utero, isn't it? So let us not call it a disease any longer. Agreed? Similarly, as long as you are a generalist, see the patient as a whole. A specialist can afford to miss something in the general physical examination and forget the whole diagnosis. It has happened several times in this thing. No, I am not this thing. It has happened. Some Waters disease have been missed, okay, etc. Of course, even Manorajan was mentioning about Waters disease. How many times it has been missed, okay. So now I am going to ask him a basic definition. What is the full definition of pediatrics? And I will start the definition. It's a branch of medicine dealing with children, okay. After that you are going to tell, then only gold medal, otherwise no gold medal for you. This I asked KKCTH people, I asked some of the Jipmer PGs, so I will ask you, undergraduates. Okay. It's a branch of medicine dealing with children from what age to what age? What age to what age? I am giving the clue. Fill up the blanks.
The branch of medicine deals with the children. Dealing with children from the age of newborn from 0 to 28 days up to 12 years.
How many of you agree newborn? Somebody started 1 month, so now they have cut off neonatology from pediatrics. No, you will not be surprised. Some PGs were telling this in St. John's Medical College. I took classes on developmental medicine. Okay, so it's not from the time of conception. Okay, from the time of conception till the time of completion of, completion of linear growth. Puberty, it can be 18 years for one child, another boy it will be 21 years, we will not know. Delayed puberty will be there. But what is important is the final height is determining the end of adolescence. After that, we can become like this, but not tall. Okay? So, as long as linear growth is there, there is a possibility of the epiphyseal fusion, last epiphyseal fusion with the long bone. So, from the time of conception till the time of completion of adolescence. Okay? Delivering what type of care? Immunization பத்தி எடுத்தாரு, nutrition பத்தி எடுத்தாரு, என்னது?
Comprehensive.
Preventive, promotive, comprehensive இல்லை, எல்லாமே comprehensive தான். Preventive, promotive, curative, rehabilitative, and he was mentioning yesterday beautifully, Dr. Julius Scott mentioned, Rajinikanth sitting, palliative care. Everything cannot be cured. Something has to be endured, and the endurance should be done with compassion. Okay, so these are the 5 care deliveries, and there are now palliative pediatricians, etc. So, delivering, what is the objective? See, I am admitting people in MD. What is the objective of teachers? To make all of them pass or fail? All of them pass. What is the pass criteria? Everybody cannot get gold medal like him. Okay, so some people can get, what is the pass percentage? 50% of the marks should be obtained, isn't it, for passing? The DNB means 150 out of 300. So, our aim is to make the candidates come up to a level of obtaining a pass certificate, and also not only that, to be a meaningful and safe doctor to these children. Okay, what is the objective? Why we are delivering all this care? I told, to help the child achieve optimum growth and developmental potential inherent in that child. Inherent means genetics. Okay, that is determined by various factors. தலைவிதின்னு வேணால் சொல்லலாம். இப்போ எல்லாமே ஜீன்ஸ் தான். பாட்டர்ஸ்னால் 5 சொல்கிறாங்க, டயபெட்டிஸில் ஆயிரக்கணக்கான நேற்று கேட்டாங்களே நியூனட்டல் டயபெட்டிஸ் எவ்வளோ ஜீன்ஸ் இருக்குதுன்னு சொல்லிட்டு. அதே மாதிரி நியூனட்டல் நெஃப்ராட்டிக் சிண்ட்ரோம், how many genes are there, they said. They asked various syndromes, neonatal syndromes with nephrotic syndrome. So, this is the most important aspect. So, we are talking about a child who is growing and developing. Now, we will call the child. நீங்கள் வந்து உட்காருங்கம்மா. எங்கே ஹேமா? Presenter, you come, sit down. You are going to be the role model. She is going to do a role play because she knows the history. She will act as a mother, and you have to ask the details which I am asking you to. Because she knows the history, she will not present. Yeah, she will be, yeah. நீங்கள் இங்கே வாங்கம்மா, குழந்தைய கூப்பிட்டு வாங்க. Hello, come here. So, see, what is his age? After 3 years of training, we must be able to at least guess the age plus or minus 2 months. அவனுக்கு விளையாடுற சாமான்லாம் கொடுத்தியா? அதை எடுத்துகிட்டு வா. So, I am asking him to do the first class. What is the first class you started this whole training with? Developmental pediatrics by which professor? Okay, so she has taken, so now you are this thing. So, this child is offering you, is interactive with that. Okay, so நீங்கள் தான் the success of the my இது உங்களுடைய ப்ரொஜெக்ஷனை பொறுத்து இருக்கு. ஓகே, நீங்கள் வாங்கம்மா, பக்கத்தில் இருங்க ப்ளீஸ். So, what is he doing? So, what is the approximate age of this child? You started seeing him walking. 1.5 years தான் வாக்கணும். அது வந்து ஃபைனல் ஸ்டேஜ். You started walking when? What did your mother say? 9 months, 11 months, 1 year. So, why don't you start a range you give? Okay. So, this child is approximately, and what will be the weight, I think? Because I told, growth and development is our objective. So, kindly guess who is, I have given the list now, we already told that. So, call by them. So, we are going to call everybody from Tirunelveli, Thoothukudi, Kanyakumari onwards to Trivandrum to Kerala, Kovai, Theni, எல்லாம் அப்படி வந்துருவோம். Whole India will be called here.
Dr. Harish Reddy, registration number 60 from Little Star.
See, he is handing over the key to me when I asked what is the developmental milestone.
Harish Reddy.
When the child offers, see, he is clapping hands. He is enjoying that sharing is good.
Harish Reddy,
Okay.
Little Star.
So this boy is, what is the weight, approximate weight? Come on, man, you tell. 10 kg. So plus or minus 1 is allowed. He is, what is the weight, madam?
9.6 kg.
9.6, so you are absolutely your dot. So 10 kg. So the age, what did you say? 1 year, 3 months, isn't it? 1 year, 3 months. Okay? Yes. So 1 year, 3 months is milestones are normal or not? Development. He came walking. Of course, what other question you will ask? He has started walking. So I asked one more step further, I asked. So whether he is climbing, I wanted him to climb the steps. So you ask, who is going to come and ask? The child is climbing, sitting in each step. And then grandmother said, the child is running, but he becomes breathless. Okay. So that means child has been, now I am going to make her play. Who is the volunteer? I have given a list, you call.
Hemant from Kuppam Medical College. Hemant.
பாரு இவன் தமிழ்நாட்டுக்காரன் கூப்பிடுவோம் நேரம் ஆந்திராவுக்கு போயிட்டான். ஐயோ நான் இதுலேருந்து தானே கொடுத்தேன். ஓகே குப்பம் குப்பம் ஓடிட்டாரா இருக்காரா? ஏய் தெலுங்கில் சொல்லுப்பா நீ. குப்பம் குப்பம் பிஜி. ஓகே எனிபடி எல்ஸ் மேனி வரலன்னா சீக்கிரம் கொடு. டைம் இஸ் லிமிட்டட். யா. So from the photo what you can see? What are the things you can tell?
Ayappan, Theni Medical College. Ayappan.
Please come faster, man. So time is limited. Your time is precious.
Jilina Jani, Jipmer Medical College.
எல்லாம் வரிசையாக வந்து முன்னால் வந்து உட்காருங்க.
காமாட்சி, தூத்துக்குடி மெடிக்கல் காலேஜ். கவிப்ரியா, திருச்சி மெடிக்கல் காலேஜ்.
Okay. So the child is
Lavanya,
1 year 3 months, weight is 9.6 kg. Growing well or not? Within normal limits? Okay. Child is doing developmentally normal or not? Okay. So now you tell what is the problem. So this child is having, can you see? Face காமிமா குழந்தைக்கு குழந்தைக்கு அந்த லிப்ஸ் முகத்தை காமிமா கையை.
காமாட்சி, தூத்துக்குடி மெடிக்கல் காலேஜ்.
So you see the picture. All of you watch the picture.
கவிப்ரியா, லாவண்யா, பிஎஸ்சி மெடிக்கல் காலேஜ்.
காமிங்க.
மனோஜ், ரயில்வே ஹாஸ்பிட்டல்.
கை விரல் and கால்.
மாதுரி, செங்கல்பட். மகேஸ்வரன், தஞ்சாவூர் மெடிக்கல் காலேஜ்.
Let them see. கால்.
மேகனா, பெங்களூர்.
Anyhow, cyanotic னு சொல்றோம் ரொம்ப already told it is cyanotic heart disease case presentation is written in your schedule also, isn't it? Last case is cyanotic heart disease by Srinivasan. It's written, so where is the fun? Okay. Anyhow,
Michael,
he is he is victoriously saying child is having cyanosis. So what is the degree of cyanosis?
Michael from Salem.
And clubbing, only cyanosis, no clubbing. போய் பாரு பக்கத்தில். உன்னை யாரும் வேணான்னு சொன்னாங்களா? அது அவங்களுக்காக அந்த இது. நீ ரொம்ப பக்கத்தில் போ. அவன் ரொம்ப கோஆப்ரேட்டிவாக இருக்கான். நீ தாடியுமே யோசிச்சு பயப்படுத்துற. தேங்க்யூ. ஹலோ. எஸ். நான் அவனை பிரைப் பண்ணல, ஐஸ்கிரீம்லாம் கொடுக்கல. ஐஸ்கிரீம் கொடுத்தது அவங்க தான். ஓகே. So what are the inferences? So come, you tell. What are the inferences? I will come there. It's nice for exercise for me. So what do you think? This child is, how many of you can appreciate child is having cyanosis of the lips? From far away you can say? If you don't, please come. Lot of vacant chairs are there. You can see the child is having what type of cyanosis? If you are not able to see from a far off distance, it's not significant cyanosis. Similarly, the clubbing is not significant. But the child is having cyanosis in all 4 limbs. Can you see the lips? Tongue. Okay. So now can you appreciate the cyanosis? Okay. Which are the areas you have to see the cyanosis? Bulba, conjunctiva and lips. Also base of the tongue. Okay. And then limbs. So I am asking you to focus specifically on the face several times and also the hands and feet. So what is my objective of focusing this whole thing? And the chest coming up. So now what is the observation of the chest? Is it deformed? Deformed. No, it's not deformed. Is there any specific precordial pulsation, prominence? Is there any Harrison sulcus as you saw yesterday in your case? No. So you find why we are focusing on the nipple? Any idea? It's on the same axis, okay, and same level both horizontally and vertically. It's same level, so doesn't show. Okay, there is no significant. Is there any pulsation, suprasternal pulsation? Epigastric pulsation? Parasternal heave. Yesterday you saw a child with parasternal heave. The ductus arteriosus. Is there any parasternal heave? So what do you call this precordium? Silent precordium. So before going to the heart, I asked him to focus on the hands. I asked him to focus on the face. What is the purpose, objective of me doing that? Yes, call somebody. என்னையா லிஸ்ட் வச்சுட்டு கையில் நான் தான் கொடுத்துருக்கேன் நான் லிஸ்ட்டு. நான் இதுக்காக நைட்டு உட்காந்துட்டு
Melba Johnson, Michael from Salem, Melba Johnson from CMC Vellore, Mohammed Shakil from KAPMC, Mohinish, Bangalore Medical College, Muthu Pandi.
See, the objective is to what? Why I am focusing? It's not syndromic. Okay, yesterday they showed, no, a child Wilson disease was there. Okay, what was the weight of the, let me see how much you remember. The child was 8 years old, Riaz was telling, but the child was having a height of 4 years, almost 100 centimeters. So child was short statured, but this child is having growth is affected. What is the height? I asked the weight you told this thing, what will be the height of this child? So what is the height, you remember?
80 centimeters.
80 centimeters, okay. So the child is growing well. So child is having a cyanotic heart disease, it has not affected the child's growth and development, okay. So what is the next question you would like to ask the model, that is mother, she is acting as the mother because she knows the history. So what would you like to ask? What will you ask? You have to ask history. What history will start? Cyanotic is a congenital disorder or defect, not disease. Again I am reiterating. Okay, so what will you like to ask? I just now asked him to tell the definition of pediatrics. It starts at the time of conception till the time of, நீங்கள் வந்து என்ன எப்போ ஆரம்பிக்கிறீங்க? Antenatal history ன்னு ஒன்றும் கிடையாதா? What is the importance of antenatal history?
Any fever, rash or
okay, infections, okay, yes, then what drugs?
Or radiation exposure,
for this cyanotic heart disease?
It can be all.
Specifically for cyanotic heart disease.
Lithium.
And I already told the precordium is quiet, there is no pulsation visible. Retinoic acid, okay, alcohol, of course, alcohol nowadays I see a lot of Pondicherrians on Saturday, Sunday, ladies also take alcohol. Okay, then what else? Diabetes mellitus, just now madam was mentioning, in mother having diabetes, they have high risk of developing tetralogy of Fallot. Phenylketonuria, you had this thing, they can have tetralogy of Fallot. So you have to ask, okay, so consanguinity history. Yeah.
Any other syndrome you want to ask the mother?
Yeah. The other one, yesterday he showed Alagil syndrome. Alagil syndrome is tetralogy of Fallot. Okay, then the madam showed, the karyotyping she was telling, what did she show? 22? Q deletion. That is very important. Dijar syndrome and conotruncal anomalies and tetralogy of Fallot. So all these things, okay, you know that I have been listening very carefully. I didn't sleep, okay, because I am telling what Riaz told and what others are telling, isn't it? So this child is having a quiet precordium, a normal growth, normal developmental for that age, okay. So the history, antenatal history is to be started from whether consanguineous marriage or not, okay. So சொந்தத்தில் கல்யாணமா அசலில் கல்யாணமா? அசல், okay. So Asal Kalyanam, she conceived within 3 months after marriage. Okay, and then she subsequently, what is the next step you will ask? Yeah, they have answered.
Family history.
என்ன
Congenital.
இல்லை ஃபேமிலி ஹிஸ்ட்ரினால ஆன்டினேட்டல்
Antenatal. Radiation exposure.
அதெல்லாம் தான் சொல்லியாச்சு ரேடியேஷன் ட்ரக்ஸ் எல்லாம். How many times she visited the doctor? Okay, antenatal checkup. And Dr. here, NRHM Srinivasan will tell what is the guidelines for visits, antenatal visits, minimum visits. Okay, she has visited 6 times. Are there a working earlier? Okay, so what would you like to know? Okay, so nowadays, it can be diagnosed much earlier because there are ultrasound machines and there are people who have been trained very well in ultrasonography. So you should find out whether this has been missed or not. Nowadays, if it is missed and subsequently you say everything was normal. It happened in Mahatma Gandhi Medical College. Child had this thing, amputation of the limb. So the limb was not there. They said normal, antenatal. When the child was born, child didn't have a hand. And it became a big this thing, It was supposed to be a police case because, they already done the sterilization because the pediatrician who went and resuscitated the child told everything is normal, but hand was missing. Okay. So that is that this thing, and then so antenatal it has been missed. They have done ultrasound, but here luckily they have gone to a person and they have mentioned the child is having a cardiac defect. என்னம்மா சொன்னாங்களா இல்லையா? நீங்களே சொல்லுங்க. நீங்க தான் பிகாம் படிச்சிருக்கீங்க. சொல்லுங்க. Tell when they diagnosed and told you that child is having a problem. சொல்லுங்க.
7 months.
7 months she was told that child is having a cardiac defect. They told tetralogy of Fallot னு சொன்னாங்களா? So they have told correctly tetralogy of Fallot. I have told the diagnosis because all of you know. Already shown a quiet heart without precardial pulsation, without suprasternal pulsation, without epigastric pulsation, silent cardiomegaly unless proved otherwise, especially with a normal development is likely to be tetralogy of Fallot.
So one point,
Okay.
sir.
Yes.
Only one point.
Yes.
Any child who is celebrating the first birthday without any
Yeah,
introduction,
that is true.
cyanosis.
That is a teaching. If a child survives without, so that comes to the next after birth. The birth was by LSCS, isn't it, madam? Yes, LSCS, and she started breastfeeding within 3 hours after birth. Okay, that means child didn't have any neonatal problem. Child was all right, no resuscitation, and எத்தனை நாள்ல வீட்டுக்கு வந்தீங்க?
Discharge on 5th day of
5th day without any problem. Child was doing well. Okay. Huh? Yeah. LSC is born normal and then went for stitch removal. Okay. And what is the next question you would like to ask? அடுத்து நீங்க 3 பேர் போலாம். Thank you. Next set of people. சொன்னாங்க ஏதோ சொன்னாங்க. Yes. Yes. Next set of people. What question you will ask? The child is having cyanotic or disease, already in the brochure itself it is mentioned. So what would you like to ask? I have told the antenatal history, no drug intake. Okay, ultra prenatally child has been found to have tetralogy.
Revati, ICH.
Thank you, dear. Thank you so much. Okay, yes. Then throw பண்ணலாமா? catch பண்ண வைக்கலாமா? போடலாமா?
கவிப்ரியா திருச்சி.
அவன் தூங்கிட்டு இருக்கான் அதனால.
மனோஜ் ரயில்வே ஹாஸ்பிட்டல். முத்துப்பாண்டி.
The important messages I have given. If a child has normal delivery, find out in the history, antenatal history, whether there is, apart from infections, we always talk about infections and drugs, try to find out and subsequently find out whether antenatal checkup, how many times they have gone, whether ultrasound has been done, how many times it has been done, whether it has been successfully diagnosed earlier. Okay, very important. Then subsequently normal delivery, and then what is the next question you would like to ask? Child's milestones are normal, you have seen that. So we asked the child this thing. So what would you like to know? Yes, tell what would you like to know? இன்னும் ஒருத்தர் தான் வந்திருக்கீங்க நிறைய பேர்.
இந்திரஜா செட்டிநாடு மெடிக்கல் காலேஜ்.
வாங்கம்மா ப்ளீஸ்.
கவிப்ரியா
எல்லாம் ஈஸி क्वेश्चन.
திருச்சி. காமாட்சி தூத்துக்குடி மெடிக்கல் காலேஜ்.
ஆஃப்டர் பர்த் நான் சொல்லிட்டேன் வீட்டுக்கு 5 நாள்ல வந்துட்டாங்க. The child was sent home and child started taking breastfeeds. There was no feeding problem. So what is the next question? We have already told what is the possible diagnosis. What question you would like to ask?
Development.
Development solliyachemma. Development is normal. Child is anybody. Child was never admitted. For what child will be admitted? Okay. She never had a spell which required admission. ஓகே அவங்க வாயாலே சொல்கிறேன். நீங்கள் சொல்லுங்கள். நீங்கள் சொன்னீங்க இல்லையா, என்ன சொன்னீங்க எங்கிட்ட? அந்த அழுக வராமலே நாங்கள் பார்த்துக்கிட்டோம். எப்படி மேனேஜ் பண்ணீங்க? இவங்கள்ட்ட சொன்னது சொல்லுங்கள்.
ப்ளூ ஆகிறது வந்து அவனை அழவே விட.
Venkateswaran.
So she was told one of the precipitating factors bluish spells is excessive crying. Okay, so she has been very this thing, and immediately she puts the child on the lap in the knee elbow position, and then she is able to control. She was taught very well by the doctor who has been treating, and then she was able to do it and prevent a cyanotic spell. She has never been admitted in the hospital. So what is the inference of this? See, first of all, we told this tetralogy fellow is not syndromic because I showed the face, except the ears is somewhat low set and the big ears, otherwise it's not abnormal ears. Okay, I have abnormal ear, there is a tubercle, I have mitral valve prolapse and mitral regurgitation. Okay, that is my father's gift. In my father's family, so many people are having. So even a small defect can be having problems. So you must understand that. This child, see, he is so curious and playing with that and active. Okay, so he has never cried and he has never gone into spell. So what would you like to ask in the history? She has been going to the doctor, antenatal doctor, they have given good advice. Then subsequently child has been, now you look at Dr. Srinivasan, he is a nutrition specialist. So I told one way she has prevented cyanotic spell. What are the other two ways you can prevent cyanotic spell? If so, what pediatrician would have prescribed? So who is going to answer? என்னப்பா இதெல்லாம் கேட்கணும். என்ன மருந்து இது, என்ன குடிப்பீங்க? குழந்தை கேட்டாங்கல்ல, when will you start iron? யார் கேட்டது? நீங்கள் கேட்டீங்கல்ல, அயன் எப்போ கொடுப்பீங்க, எப்போ இது கொடுப்பீங்கன்னுட்டு.
இரும்பு சத்து மாத்திரை எப்போ எழுதி கொடுத்தாங்க டாக்டர்?
1 monthலேருந்தே அந்த ட்ராப்ஸ் போட ஸ்டார்ட்.
Why iron drops are given very early to prevent spells? Yeah, anemia is one of the precipitating factors of spells and also sometimes failure. So it's important that child is given iron drops. What is other drops which will, if the mother says I am having, the child is having somewhat cyanosis and I am trying to prevent crying, so what drops they would have given? Propranolol drops. Find out whether they have given or not. Go and ask. You know Tamil? Yeah, please ask.
இரும்பு சத்து மாத்திரை தவிர வேற என்ன மருந்து ஏதாவது எழுதி கொடுத்தாங்க டாக்டர்? ப்ரோப்ரோனாலால் டேப்லெட் 1 மாதத்துலேயே கொடுத்தாங்களா? எவ்வளோ போடுறீங்க பாப்பாவுக்கு ப்ரோப்ரோனாலால்னா? 8ல் ஒரு பாகம் கொடுக்குறாங்களா?
So child is getting 2 important medications which are essential for prevention of the only important complication in this particular age group.
Now the recent guidelines say promoting exclusive breastfeeding, keeping the baby legs flexed, therefore it prevents.
Exactly.
Does prevent.
That is a protective measure.
In the posture.
Because already squatting is there. Of course, I don't want to ask you the basic questions, how squatting improves the decreases cyanosis and prevents. Okay, there are 2 theories. One is increase venous return from the lower, decrease venous return from lower limbs with decreased saturation, and also increase the left ventricular resistance. All these things we will know. Okay, so what is the most important thing which you have to ask? One important question you have to ask in this child. We know it's a cyanotic heart disease. What is the important question? You already answered. So
Complications.
என்னம்மா இப்போ தானே சொன்னாங்க, எப்போ சைனோசிஸ் அம்மாவுக்கு தெரிஞ்சது? அம்மா இஸ் மோர் அப்சர்வன்ட் than all of us and our grandmother. So that is the most important question you have to ask, because it was present at birth. Why it will not be present at birth? Because there is rectus arteriosus which carries blood to the, in all conditions. That's why we give prostaglandin infusion to keep the this thing for whether it's systemic dependent return or pulmonary venous return. So we have to give prostaglandin. So it interrupted aortic arch, coarctation of aorta and all is left ventricular. This thing should be there. So you have to always, whenever you approach the child, I always say, just now the whole world has understood the importance of not shaking hands. So a coronavirus has to come to tell what we have been doing all along is correct. Okay, you can greet a person by doing namaste. Now similarly, I am not touching your feet. There is nothing. So it's always nice to touch the feet. That's what they do. You must have seen Mahabharata and Ramayana. No? The North Indian culture is not totally. Okay, so they touch the feet. What is the importance of touching the feet? If the feet is cold and the core temperature, abdominal temperature is more, that means child is likely to have a shock. Okay, you can diagnose by touching the feet and dorsalis pedis conditions where there is coarctation of aorta. Okay, understand that. If only every one of you start touching the feet of the child and touch the abdomen, see there is a temperature, okay, and then feel the dorsalis pedis. If it is not palpable, then posterior tibialis, then femoral, then you will be able to diagnose clinically coarctation of aorta. Then of course you have the how to diagnose in the neonatal period after how many hours screening, neonatal screening for congenital heart diseases? At what time? Within, you have to tell 24 hours, 36 hours, and how many times you have to do?
Sir, usually at 40.
That depends from hospital.
36 to 48 hours we will do, sir.
Yeah, after 36 hours you have to do, and you have to take right upper limb, pulse oximetry reading, and both lower limb. What is the difference? Less than how much, and what is the difference which will make you suspect? 3%, yes, is enough. Okay. So difference, and persistently low, how much? Less than 90. So you have to think of a congenital heart disease and subject the child. Okay, I will take.
When do you examine in the newborn period?
Good. Okay, thank you.
Child is born, you examine immediately or? Either after 24 hours or at the time of discharge at least, when the baby is getting discharged. Okay?
So this child, when did you Neelam? இப்போ அம்மாவுக்கும் பாட்டிக்கும் சண்டை, யார் முதல்ல கண்டுபிடிச்சது? அம்மா சொல்கிறாங்க நான் தான் கண்டுபிடிச்சேன், அப்புறம் பாட்டி சொல்கிறாங்க நாங்கள் ரெண்டு பேரும் இந்த ஒன்று தான் கண்டுபிடிச்சிங்கன்ட்டு. ஏன்னா அவங்க கண்டுபிடிச்சா இவங்கள்ட்ட சொல்லியிருப்பாங்க, இவங்க கண்டுபிடிச்சா அவங்கள்ட்ட சொல்லியிருப்பாங்க. ஏன்னா கன்ஃபார்ம் பண்ணிக்கணும்ல, நான் எனக்கு பிரம்மா இருக்குதா இல்லாட்டா உண்மையிலேயே குழந்தை நீளமாக இருக்குதான்னுட்டு. ஸோ 3rd month only the child was supposed to have been detected to have mild bluishness. Okay, and then child is having normal development and growth. So what is the inference? Child is not having syndromic cyanotic heart disease. Child is not having a severe heart disease which warranted immediate operation, surgical procedure. And if that is so, already he has told Dr. Somashekar that any child living without surgical is tetralogy of Fallot or Fallot's hemodynamics, other conditions which will totally mimic because of pulmonary stenosis. Okay, so which are the other conditions we will come to later. So this child is having tetralogy. அவன் தூங்குறான் பார். கார்த்திக் இங்கே வா, நீ எழுந்து வா. என்ன உனக்கு எல்லாம் தெரியும்னா அதுக்காக தூங்குறேன் என் கிளாஸில். எனக்கு ரொம்ப அவமானம், நான் தற்கொலை பண்ணிட்டு போகிறேன். நிம்மதியாக தூங்கிட்டு இருக்கான், அதுக்கு தான் உடம்பை குறைக்கணும், உன்னை புரிய வைக்கிறேன். ஒரு 10 தடவை தோப்புக்கணும் போடு, பார்க்கலாம் வெதர் யூ ஆர் ஹேவிங் தி திஸ் திங். எல்லா காலையும் விழுந்து வணங்க, உங்கள் டீச்சர்லாம் இருக்காங்க, விழுந்து வணங்க. ஓகே, கம். ஸோ திஸ் சைல்ட் இஸ் ஹேவிங் அ late onset cyanosis starting at 3 months without cyanotic spell requiring hospital admission, but cyanotic spells aborted by mother's technique of putting the child on the knees and coitoning the child. Okay, she has been efficiently able to do and prevent hospitalization or visit to the hospital except for immunization. Okay, so that means child is likely to have only tetralogy of Fallot, and I already shown the precardium, absolutely quiet precardium, no paracardial, parasternal pulsations or heave, no epigastric pulsations, no suprasternal pulsations. Okay, so a silent cardiomegaly living beyond 1 year with cyanosis. Even in DM, I have attended along with DM postgraduates in GB Pant Hospital attached to Maulana Azhar Medical College. We are allowed to go and attend their classes also. So, whenever a child comes with cyanosis beyond 6 months of age without surgical procedure, etc., always, whatever be the discrepancy in some of the findings, always say tetralogy of Fallot are likely to be correct 80% of the times, unless proved otherwise. There will be other malformations associated with tetralogy of Fallot. But always think about it, tell to the examiner, I will think of other differential diagnosis because of some of the other points which are not consistent with the complete diagnosis of a typical tetralogy of Fallot. But you are likely to be correct 75% of the times. Okay. So this child is having. So now what is the next question you would like to ask? Yeah, whom you are going to ask? என்னையா சும்மா கை கட்டிட்டு உனக்கு இது ரெஸ்பான்சிபிலிட்டி கொடுத்தா ரெஸ்பான்சிபிலிட்டி கார்த்திகா பழி வாங்குறேன் ஒன்று எஸ் டெல்
Child is very comfortable, sir. The child is not having any symptom.
You are also comfortable, you are also sleeping. Lullaby மாதிரி இருக்கு என்னுடைய டாக் எஸ்
Any history of CCF, sir, sacral cycle, forehead sweating, breathlessness, poor weight gain, anything was there during the last 1 year period, sir?
In a sympathetic activity. Congestive heart failure. There is no congestive heart failure. Never went to the hospital except for immunization. Okay, what is important? Now, what do you think the doctor would have told? So, how would you go about counseling this mother? So, what would you counsel this mother at this age? What do you think? Child is growing well, thriving well. I told, mother now says when the child runs, child is becoming dyspneic. Okay, and child sits down. I asked whether the child sits like this or no, he sits with complete this thing. Like we sit in the those days in front of this thing in marriage halls, we will sit on the floor. So like that, that again prevents the increases the left ventricular resistance. He is not really doing the squatting. That will occur after one more year. So that means child is already having mild exercise intolerance. So what should be the advice? What should be the counseling? So till then, the counseling is normal nutrition, iron drops and propranolol drops if the child is getting more cynos in spite of her comforting the child and putting the child in that. Okay, that she has been doing regularly. The next thing is to prevent dehydration. So what is the important complications in cyanotic heart disease? Thromboembolic phenomenon below 2 years and above 2 years, abscess. So if whenever the child is having increased temperature or vomiting or decreased fluid intake, child must be coaxed to have more fluids to prevent that. That is the advice that has to be given. Counseling. Now the child is having the symptoms, what counseling should be given? So I gave the counseling in the morning. நீங்கள் நான் இப்போ கேட்டு நீங்கள் வாங்கம்மா கம்மியா. So you tell what you told me. You can tell in English because some Telugu people also. என்ன நீங்கள் என்கிட்ட சொன்னீங்களே இப்போ என்ன சொன்னாங்க உங்கள் டாக்டர்? இப்போ நீங்கள் சொன்னீங்களே என்ன பண்ண சொன்னாங்க? Yeah. So now they have told you must go for surgery. Correct advice or not? Now you tell why it's correct advice. I explained to her why it's correct advice. நீ வந்து எக்ஸாமினேஷன் பிஜி கிடையாது வாலண்டியர்ஸ் அதனால் சொல்லக்கூடாது. ஓகே அண்டர் கிராஜுவேட் கொஸ்டின் பாரு. ஓகே who will tell? Yeah, you are from? So why we have to now, the child is all right, playing well and he is not having, why should we do surgery? Tell me the reasons. Come here. So how many of you vote for the mother should go for surgery? The parent should be convinced and counsel for surgery at this age. பாருங்கம்மா நான் சொன்ன மாதிரி எல்லா டாக்டரும் உங்கள் குழந்தைக்கு ஆப்ரேஷன் பண்ணணும்னு சொல்கிறாங்க. ஸோ வாட் இஸ் த ரீசன்? Yeah, tell why we should. See, however careful the mother is, however God is kind to the child by not giving infection, there is always a chance of thrombophlebitis and thromboembolic phenomenon and even cerebral abscess, even if there is a mild bout of diarrhea. Okay, so you never know when a child may have mild ear infection, etc. So these are all preventable complications, and another important reason is, after all, brain is developing. Still, brain is developing till 5 years of age. So lot of interconnections between one neuron to another neuron, and all these connections are being done subsequently only. Okay, so naturally, if there is oxygen desaturation to the brain, okay, then there are studies to show that the cognitive ability of these children are less than children who are otherwise normal. So that's why I told you earlier, brain and the development. So it's very important that this is the ideal age to do the surgery. Okay, so
Surgery, how many of you raise your hands? This baby can lead a normal life expectancy. Please raise your hands after following total correction.
yeah,
That's really
the
great.
mortality has been found out in many centers to be 0 if the child has been operated beyond 3 months of age. Okay, where the mortality initially was only 3%. அது ரோட்டில் போனால் கூட தான் குழந்தை விளையாடினா போனால் கூட தான் அந்த மாதிரி ஆகுது.
I know one child, one of my patient who had been undergone.
ஏதோ மோட்டார் சைக்கிள் ஆக்சிடென்ட் சொல்லி யாரோ இன்ட்ரடியூஸ் பண்ணி விட்டீங்களே நேற்றுக்கு, தப்பி பொழிச்சார்னு யாரோ ஒருத்தர் ப்ரெசென்ட் பண்ணது இல்லை. So yeah, so many pediatrician children have died in accident. One of the president of Tamil Nadu, his son died in accident. So we cannot, there is always a chance of this thing, but 0% mortality. Okay, அதனால் அந்த அம்மாவுக்கு சொன்னேன், இதுதான் ஐடியல் டைமு, நீங்கள் அவங்க சொல்கிறதான் இருக்காங்க, எல்லாம் கெட்டிக்கார டாக்டருங்கள்லாம் இருக்காங்க, வெரி குட் சர்ஜன்ஸ் ஆர் தேர், ஸோ யூ நீட் நாட் வரி. ஓகே, ஸோ அப்படி பார்த்தா ரிஸ்க் இருக்குது. நான் தான் ஹெல்மெட் போடாமல் ஸ்கூட்டரில் போகிறேன் ஜிப்மருக்கு டெய்லி. My wife says, why you are going? You are breaking rules and regulations. Where is the guarantee? Okay. I don't know that. Okay. So it's very important that we have to convince the mother to have surgery at this time for the welfare of the child and for normal development. She told very specifically one particular complaint. என்ன சொன்னீங்க? குழந்தைக்கு இப்போ தான் சிம்டம்ஸ் ஆரம்பிக்கிறது, இப்போ growth வந்து தடப்படும். இது வரைக்கும் growth is normal 3 times. I said second yearல 4 மடங்கு அதிகமாகணும், 4 times it should be there. But this is the time when the child will not be catching up. Okay, so don't leave the opportunity to have surgery, because there are safe surgeons with very minimal mortality and without complications. Correct on advice earlier? Okay, so everybody advises, so don't hesitate. Bayappadavana. Okay. Okay, now you can go. Thank you. Of course, the other findings are, grandmother herself told, when I am keeping the child close to my chest, I could find the pulsations. Okay, that is right ventricular pulsation, but no thrill. I asked whether there is any purring type of feeling. Okay, so there is no systolic thrill on palpation. There is a mild parasternal pulsation in the third and fourth space, and there is a systolic murmur. There is no systolic thrill and a single second sound, and ejection click is there. Okay, so that is aortic. Okay, so because of, okay, thank you so much, sir. Thank you. எனக்கு கிஃப்டா அவங்க வேற கிஃப்ட், நீ பேசணுமா? பேசு, பாடு. So this child is non-syndromic congenital cyanotic heart disease with cyanosis onset, late onset cyanosis 3 months without any hospital admissions, with a normal chest precardium called silent cardiomegaly. Okay, actually it's not cardiomegaly, it is in the fourth space. What is this thing? Now we will show quickly the slide she has. Okay, thank you. And I have given all the questions which I asked the Mehta Hospital, where are they? They have run away. Because cyanotic already has been discussed. Mehta Hospital, PGs. ஓடிட்டாங்களா இன்னும் வந்தாங்களே வந்திருந்தாங்க they were there. Anyhow, so I had given these questions as a test. After my case discussion 1 month later, I gave this and they administered it. Those questions only will be asked, not anything beyond that. So naturally, cyanotic heart disease is going to be one of your case, and most probably they will keep only tetralogy fellow for the exam. All the other cases would have been operated upon, or they will not be in a position to be brought and handled by you in the examination hall. So kindly, she will mention, go through that, and you have to explain everything. I am going to keep silent. Okay, yes, thank you.
Good afternoon to everyone. Today I am going to present a case on behalf of Dr. Srinivasan sir.
Anybody who wants to ask questions, you can interrupt and ask questions for clarification, sir. So one of you, you are not sitting, you are going to be moving around. So you go and whomever you want to have punish for some misbehavior, you can give the mic to them. Yeah.
1 year,
Go through, yeah.
1 year, 2 months old male child is a firstborn to non-consanguineous marriage parents. The mother noticed bluish discoloration of lips and nails associated with increasing intensity of bluish discoloration with fast breathing whenever the child goes for fever and intercurrent illness. History of presenting illness, the child was apparently normal till 3 months of age. Then the mother noticed the bluish discoloration of lips and nails during the episodes of crying, which is most during the early morning period, associated with deep and fast breathing followed by increased bluishness. Initially the frequency of episodes was less up till 1 year. After crossing 1 year, there is an increase in episodes with 2 episodes per month for the past 2 months. The number of episodes was totally 5 episodes.
Why child is having a spell in the early morning cry? Why not in the afternoon cry or in the evening cry or night cry?
In early morning there will be the increased stimulation of respiratory center.
Why? That is the only
Catecholamine.
reason. Why there is increased catecholamine secretion in the early morning? The prolonged separation of the baby from the mother. Child was sleeping for 6 to 8 hours. No. When the child is awake, when the mother is not there, the child gets frightened. Where is the mother? That is the one which causes the increased catecholamine secretion. That's why when Nelson writes, the cyanosis is more in the early morning cry, not in the afternoon cry or evening cry.
It gets precipitated by crying and intercurrent illness, and it gets relieved by mother calming the child. And the negative histories, there is no history suggestive of recurrent cough, cold, breathlessness, and any feeding difficulties or increased precordial activity. No history suggestive of congestive heart failure in the form of facial puffiness or decreased urine output. No history of fever, loose stools and vomiting, suggestive of dehydration. No history of altered level of consciousness, weakness of limbs and seizures. No history of joint pain, skin rash, purpura or bleeding skins. No history of swelling of toes.
My relative himself was operated at All India Institute and he died of severe hemorrhage post-operatively. Okay, so it's very important that coagulation profile should be completely undertaken because there is a possibility of not only thromboembolic phenomenon, also bleeding tendencies are there. Okay, yes.
Past history, there is no history of previous hospitalization. And antenatally, the child was diagnosed to have some congenital heart disease. On day 3, the echo was done and discharged on day 5. During follow-up at day 1 month of life, child was started on oral medications. Antenatal history is a first pregnancy. Mother conceived after 3 months of marriage. Is spontaneous conception confirmed by urine pregnancy test. Is registered and immunized. He has undergone 6 antenatal visits and taken iron and folic acid with 2 doses of TT. Mother is not a known case of any diabetes mellitus or seizure disorder or metabolic disorder. Mother did an antenatal scan at 7th month which revealed the congenital cyanotic heart disease, and the parents were counseled about the postnatal surgery. Natal history, it is a full congenital heart disease requiring
what was the counseling given to the mother?
That the child may go for cyanosis after birth, and what are all the medicines to be given, and postnatal echo should be done and cardiac surgery.
முழுகாம இருக்கும்போது உங்களுக்கு
பண்ணலை.
When 7 months when the mother was told the child has got heart disease, then she is going to have a problem till the delivery. She will be thinking, no, what was the counseling done for that? Obstetrics உங்களுக்கு எது டெலிவரி பார்த்த டாக்டர் என்ன சொன்னாங்க?
அப்போ ரொம்ப அப்செட் ஆகிட்டீங்களான்னு கேட்குறேன்.
கண்டிப்பாக இல்லை, பிறந்தோன்னு தான் பாப்பா எப்படி இருக்கும் அதுக்கு முன்னாடி எதுவுமே சொல்ல முடியாது. பிறந்த உடனே கூட ஆப்ரேஷன் பண்ணுற மாதிரி இருக்கும், நீங்கள் எல்லாத்துக்கும் ரெடியாக இருக்கணும்னு தான் சொன்னாங்க.
Correct advice they are given because there can be a malformation, chromosomal disorder, etc. and it can also be any type. But specifically they mention pathology disorder, most probably may not be.
Do you think this would have counseling at 7th month would have precipitated a preterm delivery?
Yes, sir, due to maternal stress factor. But that can precipitate preterm
So what
labor,
sort
sir.
of counseling is needed for the mother to avoid preterm delivery?
I have to explain about the better prognosis and when the disease.
Now the mother has got a feeling. I will ask somebody also. Satyapriya, mother has told that 7th month the child has got a heart disease. Okay. Now you are going to give a positive counseling to the mother till delivery. Nothing is happening. Don't worry. How do you say? What is the positive counseling you give to the mother? Suppose you are happen to be a obstetrician. The mother is asking, sir, there is an heart disease. I am sentenced now. How you are going to give a positive counseling? The counseling there is two things, positive and negative. One of my bright MDPG, one counseling session, the examiner asked, this is a case of Down syndrome, you counsel. That MDPG told, உனக்கு leukemia வரும், உனக்கு அது வரும். That is the negative counseling. What she should have told, Down syndrome also can be intelligent, சொல்லிருக்கலாம். So I am asking you how you are going to give a positive counseling that will not affect the mother's psychology.
The baby has got some congenital heart problem, but we have to evaluate after the all heart disease are now treatable, so she need not worry about it.
இல்லம்மா அடுத்த 8வது மாசம் வர 9வது மாசம் வர உன் பாப்பா நல்லா இருக்குன்றது எப்படி சொல்வீங்க?
Weight gain of the baby, baby is improving.
So you have to tell the mother how the baby is progressing in utero. If there is an adequate weight gain, the mother is feel, then the mother will be confident this heart disease is not any much problem in utero. That will give a lot of positive effect on the mother's psychology, so she will not get afraid. The baby is growing well. That is more, see, any mother, the intrauterine growth is very important. And the mother feels the baby is growing nicely, whatever be the disease, at least 50% she will feel all right. So that sort of positive counseling. மா உங்களுக்கு முழுகாமல் இருக்கிற டாக்டர் பாப்பா நல்ல உள்ள வளர்ந்துட்டு இருக்கு பயப்படாதுன்னு சொன்னாங்களா?
பாப்பா வெயிட்லாம் கரெக்டாக தான் இருக்கு. அதுக்கப்புறம் இன்னும் சரியாக தூங்கல.
I am a typical NICU nodal officer. I am worried about the antenatal period, whether the mother has slept or not. When somebody is making a diagnosis at 7 months, see, she was so tense for 3 months. That means the counseling was not good. She was not properly or positively counseled. That is very important. When you find one disease, you should tell the mother. Okay? Serima, ide papa, now I will ask somebody. Sibi, now this mother has gone to the pediatrician. This mother has gone to the pediatrician. The mother said, I have got an in utero baby with some heart disease. She has gone to the pediatrician. Sir, what will happen? What is your counseling?
Sir, there are possibilities that child can be salvaged by early corrective surgeries. We can
I am not going to talk about surgery.
I will advise exclusive breastfeeding for the first 6 months. In the mother, to the mother.
That is a positive counseling I give. I will not talk about surgery. You are not going to do surgery in utero.
No, sir.
Then why do you talk about surgery?
Say for example, I told just now I am having mitral valve prolapse. Okay. Similarly nowadays, mitral valve prolapse, whether to tell parents or not, whether you diagnose is a big question. So if I don't tell, if I see a child with mitral valve prolapse, okay, if I don't tell, what will happen? Another doctor will say, what did they think about me as a pediatrician and this thing. இந்த டாக்டர் ஒன்றுமே சொல்லியான்னு சொல்லுவாங்க. So it's better to tell them there is no problem with that. Okay. So enakku heart disease porapla irukku and the leakage irukku inga veetla
Natal history, it is a full term LSCS. Birth weight was 3.6 kg, cried after birth. The breastfeeding was initiated after 3 hours. Nutrition history normal, no summary. Summary, it is a 1 year 2 months old male child presented with cyanosis and clubbing at 3 months of age, with recurrent cyanotic spells for the past 2 months, with no recurrent respiratory tract infections and futures of congestive heart failure, with developmentally normal child with no protein allergy, malnutrition.
She said recurrent cyanotic spell, which I am not agreeing. She had managed, prevented cyanotic spell. Child never had problem in sleeping immediately. So never rush to the hospital. Cyanotic spell means needing hospitalization. Okay, yes. Then
Must be probably is a cyanotic congenital heart disease with decreased pulmonary blood flow. On examination, child was alert, comfortable, looking around.
distal clubbing, which is unquestionably present in all the 4 limbs, no deformities. So why you have to look at the toe? What syndrome will have? So other syndromes, Kabuki syndrome will have. What is Kabuki? German people know, just like Kathakali they put mask. Similarly, German people they put eyeglasses, etc. And that's called Kabuki syndrome. It is given as the last cause in the list of congenital syndromes causing cardiac malformation. It was kept in DNB examination in Delhi, and the local examiner from Maulana, that she was insistent that they should know about Kabuki. Then I had to tell, no, Kabuki syndrome is not so common, so it's not necessary that all of them should know. That as long as they know there is a syndromic phase, it's not necessary to tell the face. Okay, so I have to tell and this thing. So it's important that you need not know all the syndromes, but you should know that there are some abnormal facial features and other things. So Rubinstein-Tyaby syndrome, have you heard of it? So the toe will be, thumb will be big, broad, and similarly short, and also the toe will be very broad, okay, spade-like. So that is also another condition where you will have pathology. Yes.
Vitals were normal, pulse rate is 130 per minute, regular rhythm, normal volume, no specific characters, all peripheral pulses equally felt, vessel walls normal, respiratory rate 40 per minute, regular abdominothoracic type of respiration, blood pressure was normal, temperature normal, saturation was 88% in upper limb and 78 to 79 in the lower limb. Anthropometry, it's normal. Inspection, trachea in midline, no precordial bulge, apical impulse felt to the 4th intercostal space in the midclavicular line, no visible pulsations seen over the neck, suprasternum or epigastrium. And palpation, tracheal position confirmed, apical impulse normally felt over the 4th intercostal space in the midclavicular line, no associated thrill, a parasternal heave or palpable sounds. A percussion, left border corresponds to the apex and right border corresponds to the right sternal border. Auscultation, in aortic and pulmonary area, the S1 was normal with single S2. The murmur of grade 3/6 rough ejection systolic murmur, best heard in the left 3rd intercostal space and also in 2nd, 4th intercostal space, associated with ejection click. There is no murmur felt over the interscapular area. Respiratory system normal, per abdomen soft, no ergonomegaly, CNS no focal neurological deficit. So diagnosis, it is a cyanotic congenital heart disease. It's with decreased pulmonary blood flow, probably tetralogy of Fallot, which is child is in normal sinus rhythm, no signs of congestive heart failure, no infective endocarditis, with normal nutritional status, developmentally normal child. The differential diagnosis I would offer me.
So what are the complications will be questioned, we already mentioned. Okay, as the age advances, then there is moderate polycythemia, severe polycythemia. There can be consumption of clotting factors, etc. Bleeding disorders can be there, gout can be there, arthritis, etc. Depends upon the age of the child when the child presents to you. Okay, yes, but not in this child. Next.
The differential diagnosis, closest differential diagnosis to tetralogy of Fallot is DORV with pulmonary.
Wherever there is decreased pulmonary blood flow, the morphology will be same. So nobody is going to be failed because, but always I told you, DM cardiology students are also taught the same way. If there is a decreased pulmonary blood flow with a normal size heart without any abnormal pulsations, except epigastric pulsation, always first diagnosis 95% will be tetralogy of Fallot. Then you tell it can be DORV pulmonary stenosis, which will also be the same syndromes will be there, which I told, congenital syndromes they can present, DiGeorge syndrome and etc. Okay. Yes, then TGA with PSD with pulmonary stenosis will exactly present, but there will be mild cardiomegaly. Okay. Yes. Single ventricle physiology. We have had Down syndrome with atrial septal defect. Okay. Biventricular defects. Okay. Single ventricle in Raleigh Hospital because it's a center for cardiac surgery. I take classes there for DNP students regularly. So they bring 2 days all the cases, variety of cases. So we found 2 cases exactly presenting as tetralogy of Fallot, but echo showed single ventricle with pulmonary stenosis or atrioventricular canal with pulmonary stenosis. So always think that these possibilities are always there. So when the examiner goes on asking what next, what are the differential diagnoses, always tell these diagnoses. Understood or not? Okay, yes.
Chest X-ray, there is a pulmonary oligemia with normal sized heart and apex is up
right side and this thing,
river.
okay. And there is, of course, this is a overexposed film so that you can see the vertebra and intervertebral space, not an ideal film. Next, ECG is very characteristic. What is characteristic in ECG?
Right axis deviation.
So V1 will show
V1.
only R wave, but there will be quick
Deep
transition
S.
zone with
Deep S wave in the right precordial.
And then you can see there is a ventricular volume overload. You can see the talls, it is not due to hyperkalemia, but you can see a symmetrical tall T wave. Okay. So this child is having volume overload of which chamber? Which chamber? Left ventricle. Okay, yes, next. So what is that? Only God can read. Yes.
Echo finding in tetralogy of Fallot with large perimembranous subbiotic VST with bidirectional shunt with overriding of aorta with severe right ventricular outflow obstruction with valvular PS with no coarctation of aorta and no PDA.
Okay, yes. So these are the questions she will quickly go through and she will be taking your so no, it's being given, no, all of you have asked for the all the questions are the same. You will get it. Why you want to take photograph? If you want to take photograph, you can take. You have enough space in your cell phone.
Why cyanosis occurring late in infant with TOF? Due to a fetal hemoglobin which has increased affinity to oxygen, so child develops late and the child goes for the activity after 6 months of age, which increases the oxygen demand, will aggravate the cyanosis, and the pulmonary infundibular stenosis which goes in proportional to that of growth of the baby, so which aggravates the cyanosis in the later half of the life. What are the genetic and chromosomal conditions that have TOF as a predominant association? Chromosomal abnormalities, most commonly Down syndrome, Edward and Patau syndrome, and genetic conditions discharge with Catch22 chromosome defect, Alagili syndrome. What are the 4 components of TOF and which one is hemodynamically vital, determining the hemodynamics of this condition? Which IEM in a mother will have association with the TOF in the baby? Phenylketonuria. What are the complications of cyanotic congenital heart disease and TOF in particular? What's Fallot's pentology and what are the usual characteristics of associated VSD with the TOF? What are the other commonly associated congenital and vascular malformations of tetralogy of Fallot? What are the 5 palliative shunt procedures historically performed and what shunt is more commonly performed when required under the certain situations? Man's important contribution in the development of Blalock-Tasic shunt because of the racism prevalent then in USA was later surely acknowledged and his name was got included. What was his name and what was his contribution in the operative procedure carried out by Dr. How will iron deficiency anemia be recognized? Ideal PCV and hematocrit value to be maintained above which the complications would arise. Propranolol.
Propranolol, okay, if necessary. Yes, next. This
Uh,
child, of course, is having mild knuckle pigmentation. Okay, I have seen, and no, so I asked them to give B12 because I am sure this child is likely to have mild B12 deficiency. Yes.
What is hypercyanotic spells? Why and which age group it occurs commonly? What are the precipitating and relieving factors? What is the mechanism and what happens to the intensity of murmur during the spell? What are the treatment and options for spell? What preventive measures to be instituted and informed to the mothers? How does the squatting relieve the symptom and mechanism? What does its presence as a symptom indicate? What are the other cyanotic heart disease where a spasmodic spell occurs with history of squatting can be obtained?
Thank you. So why I am telling this is important because no other cardiac disease will be kept for the examination, cyanotic heart disease. Most of them will be either operated or managed, okay, and or they may not survive. So if at all a cyanotic heart is given, is most likely to be tetralogy of Fallot with this thing or its variant, one of the variant. Okay. So kindly remember, most of the questions are the same for all the types. Okay. Kindly prepare and be ready. Just like thalassemia frequently asked questions, you should know about for these questions. Thank you very much for your patient listening and cooperation. And I wish you perform well in the examination and try to prove my point.